Namaskar and hello everybody. Welcome to the third session of Critical Lines. So today on our podcast, it is a privilege to have Dr. Raj Shekhar Chakravati sir, and he has been a very active contributor on a platform to teaching the critical care community. So just to introduce sir to everybody, in one line, he is the leading exponent of acute kidney injury in our kidney and has done a lot of work on acute kidney injury. Sir is the director and the HOD of clinical nephrology and transplant at Eastwood Hospitals, Hyderabad, India. He is a member of AKI committee, International Society of Nephrology, and he was faculty Kidgo for AKI Consensus Meet 2019, and he is the editorial member for Indian Journal of Nephrology. So we will start now, sir. So the first question is, can you please tell us about the recent advances and developments in critical care nephrology over the last 2-3 years?
Thank you. Hope I am audible.
Yes, now you're audible, sir.
So, recent advances per se, I don't see major change, but there have been a lot of new concepts that we understand today. As a nephrologist, it is my duty to convey one of the things that we understood in the last 5 to 10 years. Start to most of the acute kidney injury, which you see in the will get translated to what we now call as AKD. That is, after the 7 days of AKI, somebody has any abnormality in the kidney function or urinary abnormality. The term now we coin is AKD or acute kidney disease. So, as a concept, every acute kidney injury can potentially become a chronic kidney disease. So, by definition, the chronic kidney disease will be after the 90 days. So, between the 7th day and the 90 days, we talk about the acute kidney injury. So, one concept that people go home with is about AKI to AKD to CKD. This is one concept. The second thing that I would like to highlight is whenever you are treating a patient in the ICU, please do not look at on that day's intake output chart. Please look at the cumulative fluid balance. I will tell you the rationale for this. Many times we talk about dialysis being done in the ICU, which is for a solute clearance. Somebody has a very high urea or a very high creatinine or a potassium or acidosis. So most of the times your indication for RRT will be uremia, high creatinine, potassium, acidosis. In the last 10 years or so, it is extremely clear your outcomes, not only short term, but even the long term outcomes of an ICU patient to some extent depend on the volume. So when somebody is hypervolemic, all the organs in the body, including the kidneys, swell up. The liver is congested, the kidneys are congested, the lungs are congested, the cardiac output can be low. So you don't need any other reason except a increase in the fluid volume in the body, which could be just a increase of 10% from the baseline body weight, affecting the organ functions. And initially, we thought this decrease in the organ function is limited to one organ, like the heart or so. But now we know it is every in the brain, which has lot of effect on both the short-term functions of these organs and also the long-term outcomes. For example, somebody can develop a new onset acute kidney injury because of a fluid overload state. And this acute kidney injury may transition to CKD just because of a fluid overload state. Most of you will be aware about the abdominal compartment syndrome. Somebody can have a hypervolemia. The abdominal may increase, and this can cause significant amount of rise in the intra-abdominal pressure, which leads to other organ dysfunction, like including the kidney. So the first thing we discussed is concept of acute kidney injury, going on to acute kidney disease, going on to chronic kidney disease. The second concept, just the volume in the body in various compartments, causing new onset organ dysfunction, also leading to chronic organ dysfunction in these organs. So I would like to convey these two as a take-home messages from this discussion today.
Thank you, sir. Thank you. So moving on, sir, creatinine is the marker we use generally, sir, to estimate renal function, but it has its own advantages, disadvantages. So can you please talk about that, sir, and what other options do we have?
Yeah. So very relevant. As I just discussed, we are now focusing on picking up acute kidney injury earlier and earlier and earlier. As we understand, most of the rise in serum creatinine is a delayed diagnosis of AKI because there is a lag between the drop in GFR and rise in the creatinine. Sometimes this lag can be more than 72 hours. Your GFR may start dropping on Monday morning, but by the time you see on paper a rise in creatinine, it could be Wednesday morning. Keeping this in mind, again, I would like to stress every day go by the cumulative fluid balance rather than a serum creatinine. So, if somebody has a volume which is accumulating, that itself should be a flag, red flag for us. These patients need to be monitored closely. Second thing, once we know creatinine elevates later, people have looked at what is known as cystatin C and a list of other biomarkers which are injury biomarkers for the kidneys. What is available to us in India today is NGAL is available, and also there is a test known as NephroCheck, which is a urinary marker and a product of two different biomarkers, TIM2 and IGF-B. So both of them together, when you look at, you are likely to pick up extremely early. And we were part of a study called Biomarkers study, which is biomarker enhanced AKI in the country, which was done across 10 centers. And we clearly found that when you use a biomarker like NephroCheck, you can pick up acute kidney injury much before the rise in serum creatinine. So please do not be creatinine centric. Look at your patient on a daily basis, cumulative fluid balance. Look at other things like acidosis. That would be your indication for dialysis rather than a particular fixed number of creatinine or urea. Or you can always use biomarkers. There are several published data which talk about biomarkers trying to predict outcomes, both short term and long term, also RRT modality. These are important concepts because we now know early RRT is not the sole thing to improve the outcomes, but at the same time, a delayed RRT becomes a futile RRT because once acidosis sets in, organ dysfunction, hemodynamics, all of them do deteriorate in that particular patient.
Thank you, sir. So now you have mentioned RRT, sir. The next question is about RRT. When to start and when to stop RRT as of now, sir? What is the development?
So, as I just mentioned, if you look at the spectrum of management of AKI, we know now most of the RRT was started after the decrease in GFR, rise in uremic toxins, volume being excess, acidosis being excess. The good thing now, and the concept again, which is recent, is to look at what is called as a demand capacity paradigm. When you say demand capacity paradigm, you are looking at your patient more frequently and at least once or twice a day and see what is the output of the patient. For example, let us say the patient has a liter of urine output. We know that the patient is getting next 24 hours nutrition, transfusion, antibiotics, all of them together more than 2 liters of intake. In which case, the patient's capacity is to excrete around a liter, but the demand on the patient is going to be more than 2 liters. So when you look at a patient in this paradigm, this is the demand on the patient and this is the capacity of the kidneys. You know easily you can start RRT because you believe by your assessment in the next 24 hours, this patient cannot handle the solute load, this patient cannot handle the solvent load. Therefore, you are wanting to initiate RRT. This concept will allow you to not delay the initiation of RRT, which itself, as I just mentioned, is a very, very important concept. The other thing to look at is to look at hypercatabolic states of the patient. By definition, a particular amount of raise of urea in 24 hours, creatinine in 24 hours, phosphorus in 24 hours, potassium in 24 hours, or drop in bicarbonate in 24 hours can become part of a definition of a hypercatabolic state. So you look at your patient, a patient who is hypercatabolic obviously cannot meet the demand capacity paradigm and needs to start RRT earlier. When it comes to stopping RRT, it is not as simple because there are no hard and fast rules. Traditionally, we look at increase in the urine output when it is more than 400 or 500 ml in a day. You start looking closely at the patient. Is there a possibility of weaning off from RRT? The second thing you can take into consideration is on a daily basis what is happening to the urea and creatinine and potassium. So without dialysis, if the output is increasing and the decrease in urea creatinine the next day morning will obviously tell you that this patient is probably improving. The furosemide stress test, which was given as a role or has a role in deciding when to start RRT, has been looked at as one of the measures to decide when to wean RRT also. When somebody failed a furosemide stress test earlier, started on RRT, after 4 days, output is 400, you do a furosemide stress test, he has a good response, that is an indirect indication to you this patient may come off RRT in the next 1 or 2 days. Lastly, there is something known as timed collection of urinary urea and creatinine. So you believe this patient has made today 400, 500. In that 400 and 500 ml, start seeing how much urea and creatinine is being excreted. If it is increasing day on day, it is an indirect indication to you, and this is validated in certain cohorts that is a very good marker to decide when to stop RRT or when to wean RRT from this patient.
Thank you, sir. So moving on to the most important issue in the ICU for intensive is sepsis. So when the patient has sepsis, sir, he may get acute kidney injury either as the sole manifestation of sepsis, what is called sepsis-associated AKI, or as part of multi-organ failure. So what is the best strategy and what ways are there to, kind of improve the outcomes with septic AKI and how should we go about it, sir?
So it is a little complex question and it will take a lot of time to answer. To put it very simply, we do understand the pathogenesis of septic AKI much better now. We know that you don't need shock to have AKI. And it is actually the shunting of blood from the afferent arteriole to efferent arteriole, which causes drop in the GFR. And a septic AKI is a little more complex because there are at the molecular level what we now know as PAMs and DAMs and their interaction with the receptors and the tissue perfusion at the molecular level, at the cellular level, which is leading to acute kidney injury. So when you have septic AKI, as I already mentioned, probably these people will have a hypercatabolic state. You should have a lesser threshold to start RRT. Make sure they don't develop complications like volume overload and acidosis. Because once acidosis sets in, hemodynamics can be worse. These patients need to have a regular, good clearance of solutes. You could start IHD, but most often septic patients, we want a convective clearance. Most of us are now moving on to HDF. But if they are on more than one inotrope, we do want to consider different modalities of CRRT. I would suggest every unit to have a default prescription, either for HDF or for CRRT. And this default prescription, everybody in the unit should be clear about. The default prescription is a minimum amount of clearance that you have to achieve, below which the outcomes are not good. So you look at early initiation, you look at the modality of RRT, and then you try to get a convective component to it. If it is possible, always use a membrane which has a higher flux and therefore has a role in also removing certain septic cytokines. Finally, before we close, I would like to bring in the concept of various what we now call as septic filters. We have published a consensus on nomenclature on the filters. If I can send it to Tapesh and anybody else is interested, I can share it with them. We now understand sepsis needs solute clearance, solvent clearance, cytokine clearance, and there are certain instances wherein you want to remove a particular substance. So I am trying to talk to you about using filters which are either removing cytokines or endotoxins or which can do both. And this concept has now come a long way, and there are various filters available in the market. So to summarize, please look at your patient every day. Try to assess the patient's catabolic status. When you want RRT, look at the demand capacity paradigm. If the patient's capacity is not good or the demand is more than the capacity, start the RRT early. Choose a modality which has a convective component. Always look at cumulative fluid balance in the ICU. You can think of starting ICU with taking help of FST, or you can always look at the volume of the patient, potassium, acidosis. But when it comes to weaning, you should look at increasing urine output, decreasing azotemia. Also, some authors have published role of FST. We do use bedside the timed urinary urea and creatinine collections. Modalities of sepsis, we can use HDF, CRRT, and also any good unit now should be familiar with the septic filters that are available to remove endotoxin, cytokine, or both in our setup. Thank you.
Thank you, sir. Please share the papers. I will put it up for everybody. Thank you.
Yes.
So, last and final question, sir. What is the current role and use of SLED compared to ISD and CRT as a means of RRT?
So, Tapesh, I'm very happy we are discussing this. Many people ask me which is better, SLED or HDF or CRRT. So, every good unit should have the entire spectrum of IHD, SLED, HDF, CRRT available. A particular cohort of patients will be benefiting from any one of this. I'm not mentioning peritoneal dialysis because many ICUs may not be having the wherewithal of doing a acute peritoneal dialysis, but we should have experience and we should be able to offer any one of these modality to the patient depending on the requirement. There is published data from our country which talks about once SLED is being introduced into ICU, the CRRT requirement or usage has come down significantly, 40 to 50% decrease in its usage, which is the right thing to do because the cost of SLED will definitely come down. But there are patients who are on more than 2 inotropes and you need volume removal, but hemodynamics don't allow you to remove more than small amount. And the best thing is to not achieve more than 10 ml clearance. When you get into those situations, worsening hemodynamics, lot of volume is there, you cannot remove in 4 hours or 6 hours or 8 hours, you should consider doing CRR. But a particular patient can have one modality of dialysis today. For example, let us say I started CVV HDF on a patient. After 2 days, patient's hemodynamics are better. I should be able to transition to HDF. On HDF, he may move out of ICU. In the wards, still anuric, I may want to move over to regular hemodialysis and then discharge the patient. So these concepts of transitioning from one type of RRT to another and a default prescription when you start first day are very, very important to set up a good RRT program in the ICU. Again, these are all covered in the ADKey papers which came from Hyderabad. I will share those also to those 6 papers to Tapish. So with this, I think we have discussed certain salient concepts that we understand better today than earlier. The most important being, please treat your AKI patients fully being aware tomorrow they may be contributing to the CKD burden of the country.
Thank you. Thank you very much, sir. Dr. Raj Shekhar Chakravati, sir, indeed a pleasure listening to you. Words of wisdom for me and for everybody. And we will put this up on our YouTube channel for the students and young intensivists and the senior intensivists also to kind of go through, and those who were not able to understand. And thank you to the audience for their patient hearing. Thank you, sir. With your permission, can we close now, sir?
Yes, good night. Have a great
Thank you very much, sir. Thank you.